Ada has a question. Go ahead, Ada.
Hi, can you hear me okay?
Yes.
Yeah.
Okay, wonderful. Thanks for all your wonderful work, first of all. My question's a bit, I guess, broader. I was interested if you could touch upon more of addiction prevention. I'm the Vice President for ARPO, which stands for Advocates for the Reform of Prescription Opioids, and we just released in Canada a national strategy called First Do No Harm, and one of the recommendations in that strategy does touch on naloxone, and I'm going to do my very best here in Canada and with this strategy to try to promote that. But at the other end, I'm really concerned about anything your group is doing as far as addiction prevention in the way of overprescribing of addictive drugs such as opioids. Is there anything you can tell me about that?
Yeah, absolutely. I think that we have a program in the United States called Project Lazarus in North Carolina, and their bent from the beginning was to engage medical people in thoughtful prescribing of opioids and co-prescription of naloxone in every case where a significant amount of opioid was prescribed. That has shown, I think their latest figures are a 2/3 reduction in opioid overdose fatalities. There's no doubt, in Canada as well as the U.S., especially in more rural areas, that pharmaceuticals represent the number one overdose contributing medicines. The one difference, of course, between street drugs and pharmaceuticals is that pharmaceuticals, you know the amount you're taking, but based on some of the delayed onset and so forth, multiple prescriptions for benzos and opioids and the combination with alcohol and whatnot, there are some pretty complicated mixtures. I dream someday of a way to recognize the maximum overdose risk moment based on what someone has ingested and when. And I think that's very possible to do, but currently it's unavailable. And the thoughtfulness of, we have taken the approach for many decades in this country, and I think in Canada as well, that keeping the product from people, in this case heroin, cocaine, whatnot, is the way we stop addiction. And I think one of the things that we've learned over this time, and this is the new drug strategy suggests this, is this intoxication is a very human condition, and it has been through all of recorded time. So despite the fact that physicians aren't prescribing to intoxicate, us humans are intoxication prone, and that's as strong a drive as any other drive we have, innate or otherwise. And so I would say that if efforts to deal with addiction are going to be successful, they need to be smart and not kind of quashing as they've been in the past. And let me give you an example. Well, obviously the effect of law enforcement incarceration, brutal, ineffective, and does nothing but maintain price supports for drugs, illicit and licit, especially in a misusable sense. That is our lesson here. So what can we do new that hasn't been done before and that might have a chance of success? And coming from that orientation, and when there's been a federal effort to address overdose, one of the big things that's come out from that are something we called prescription monitoring programs here in the U.S. And these are ways for, it can be really dramatic. We have the toughest privacy protections we've ever had, supposedly, in a law called HIPAA. But in fact, the police are more informed of what prescriptions happen between physicians and their patients now than they ever have been. And I would not call that intense privacy protection. But nevertheless, if it was effective, that's something. The Centers for Disease Control here did a couple studies around a year ago that concluded that prescription monitoring programs were not only ineffective, but they were counterproductive. But the politics around the whole thing, coercion, control, siphoning off the supply, this kind of mentality exists in prescription monitoring programs are adopted by most states in the U.S., although there's no evidence of effectiveness. The problem with this, like incarceration and law enforcement interdiction, is that it doesn't work. So if you hold out for your for overdose prevention and the less deaths, less sickness, we talk about overdose death, but I think it's important to talk about there are plenty of people here, as I'm sure well as there, who suffer oxygen deprivation injuries, and these are neurological and otherwise, and they can result in many, many months of intense hospitalization and massive costs. Prescription monitoring programs, expensive. Interdiction, expensive. Law enforcement, incarceration, expensive. Yet, as I said, I spend most of my time begging for money to do something that has shown itself to be effective over decades. We need to have a kind of willingness to address the effectiveness of the interventions we try and to make sure that they're proven worthy, and then invest in them. As I say, it's the question, how much is a life worth? We can spend $50 million on prescription monitoring programs in Illinois, and we have spent a total of, well, let me see, $0 on overdose prevention in Illinois. And from this, I'm talking from the government. We're applying to the city now, who just has created an RFP that it might be applicable, overdose prevention. But addiction prevention is a very challenging thing, especially when intoxication is so normal. My suggestion, as someone who's focused on public health and drug use for a long, long time, is that there will be a portion of people who abuse, there will be a portion of people who become dependent, but for those people, we need to have help in as user-friendly a way as possible, immediately available and accessible to them. And the only way to do that, as far as I can see, is to accept the harmless intoxication that comes from it and use that to generate resources for the help that I'm describing. And I personally just do not see of another way. And I'm 54 years old, and I'm not a real government trusting person in general. I'm kind of a Watergate baby, but you have to, if you want to be practical and effective, and lives depend on it. And as I said, I've seen over 4,000 reports of lives extended through naloxone. You want that at all costs, and one of those costs is reconsidering some of the coercion and oppression approaches. There may be some utility to it, but let it be proven, and let's focus on that. And then, of course, dedicate the resources according. I'm talking about taxation of cannabis. That in and of itself, cannabis has never caused overdose. This gateway drug thing is nonsense. This is a drug that is far safer than alcohol. It could generate revenues to support this mentality, but thinking in that way, to me, is the best way to address what I would call secondary prevention of addiction. I know of no other way to address that. One thing we could certainly do is talk with our kids about addiction and openly, and avoid some of the stigma which isolates and silences, in a sense condemns, which is a very costly social intervention. Does that get at what you were saying?
Well, thank you. Yeah, there's a lot that I agree with what you've said, but I guess our group is more focused on preventing new starts, and I hear what you're saying, but a lot of the doctors do not have the necessary information as far as what opioids do, the dark side of opioids. And I think there was a marketing push by drug makers, and in the 80s or 90s, I believe it was, where doctors went from being very careful when they prescribed opioids to being told that less than 1% would become addicted. It is this information that is bothersome to a group like ours.
You raise an excellent point about doctor education. I'm always surprised why a physician who gets somebody on opioids for any length of time doesn't also take on the responsibility of weaning them off collaboratively. You know, so many people just stop it, and that produces a lot of the problems that you described.
Right, and they go to the street, but
right.
Oftentimes it's not as easy to taper people off these drugs. So I guess
let me just say that is one of the great things about pharmaceuticals. We know their dose, we know their purity, and tapering is magnificently easy if done as part of the entire process. I can't tell you how many physicians don't include that. What they get, if there's any suggestion that the person is may becoming dependent on the medicine, which by definition people are, the physician shouldn't be Pollyannish about it. They should say, here's a medicine that has some potential to produce dependence. Opioids certainly aren't alone in this. And if you're going to take it to relieve pain, which I suggest because of its price, because of its effectiveness and side effects and so forth, then we need to talk also about when you're going to get beyond, if you're going to get beyond this period of necessary pain relief to reduce. And this kind of thoughtful prescribing is largely absent. In the United States, what's developing is a kind of coercive effect. Look at people's pee, take their pee, develop contracts, threaten, call people in to count their medicine. You know, what I would call oppressive and proven ineffective strategies. If we are thoughtful enough, we can do thoughtful opioid prescribing. Methadone, for example, as a long-acting pain reliever, has not suffered from promotion like Oxycontin has and other things, as the point you make, which is an excellent point. But it's cheap, very cheap, and that's why a lot of people prescribe it for chronic pain relief. But people need to know that when and if you need to reduce, you need to do it very slowly. But it's not magical. It's just, you know, the nature of the drug. But because we prefer to bury our heads in the sand about that reality, I think we produce a lot of problems. And to me, that would be the number one thing we could do. Instead of driving people away with their dependence, we should be engaging them. And right now, you're not empowered to do that as a physician in the United States. For example, if you're prescribing, let's say, methadone for pain relief, and it goes on for a period of months, and the person has some level of dependence, the minute you work with them on potential dependence on the drug, you are violating the law. You are prescribing methadone not for the pain, which let's say the condition has faded. You're prescribing it for addiction. And that is illegal for a private physician to do in the United States. I believe in Canada, physicians can do that, can't they?
No, I think for addiction, I'm not sure. But, gee, I'd like to talk to you more, but I think our time is up. But perhaps I can email you.
Anytime. Let's see, I think my email should be here somewhere. Oh, here it is. So I appreciate your comments, and I wish you good luck with your work.
Thank you.
Thank you. I'm not seeing any additional questions. So, Michael, I'll turn it over to you.
Great. Thanks, Christine. I just want to thank you so much, Dan, for all the work that you have done and sharing your time with us here today. I know you're a key part of it, but always in collaboration with others, and the grassroots nature is inspiring, and I think we're probably in the same boat as USA might have been 15 years ago, where there really are no leaders in charge, and it's up to us on this webinar and beyond to advocate for what you point out is a common sense solution. And it's by my experience that once you have a few minutes with someone, they get it intuitively. It really is a no-brainer. So in that regard, thank you to all Chicago Recovery Alliance. Thank you to the participants for joining us today, and great discussion. Fascinating. I could listen all day. Just a reminder to people that this webinar series, I think we've done 13, and in total, they're all being recorded and being chopped up for YouTube consumption. So this will live on for quite some time. If you're interested in drug-related issues, that's my Twitter feed down there. Please feel free to join us. Also a reminder to folks to share the film Eyes Wide Open. The experience has been very positive. It's about 5,000 people have seen it at least. But what the positive part of it is that it's opening doors in some of the quarters where we want to open doors in toxicology and in poison control and so on and so forth. So feel free to share it far and wide. There's nothing in it for us. We don't get a cut. We take a hit. So again, thank you so much. Thank you, Dan. We'll be back this afternoon, in about 54 minutes with Dr. Kieran Moore, who's going to talk about real-time monitoring in hospitals so we can catch adverse overdose events, not just death, but also injuries in real time, like we do for other health events. So thank you so much, everybody. Take care and have a delicious day.